So the next session will be on regulatory framework of biomedical waste management in India. So from morning, you all know about Deepthi ma'am. So she is a Chief Quality Officer and Infection Control Officer from Caritas Hospital, Kottayam, Kerala. So she has been the key speaker in most of our regional workshops that is conducted, and she has a wide experience with the participants. So I request ma'am also to join back in our FAQ discussion, and once the session is over, all the queries related to the previous sessions will be addressed by Dr. Aruna ma'am and Dr. Deepthi. So over to you, ma'am.
Thank you so much, Malathi. So good evening. We have moved on from good afternoon to good evening. It's a weekend. It's the fag end of the day. I'm sure you're all looking towards the gathering as much information in as short a possible duration of time as possible. So I'll try to stick to the script and I'll try to make it as concise as possible. And all questions will be taken at the end of the session. So regulatory framework and biomedical waste guidelines in India, the current scenario and what is applicable as of now. A lot of it has been covered during the course of the day in various sessions, but I will be reinforcing the same. I'll be reinforcing the same, and you can think of it as a possible revision and gathering of all the essential information in one small session. So, by BMW rules. So where exactly or what exactly is the need for these rules? As in, we all, even during my discussion, I said, we all have good intentions. None of the hospitals or none of the healthcare providers have any bad intentions. We all have the best intentions at heart. And if every institution says, I am discarding biomedical waste as friendly to the environment as possible, isn't that enough? Why do we need to have rules? Why do we need to have uniformity among the institutions? Because biomedical waste is generated in each healthcare facility. But the story of biomedical waste starts there. It has a long way to go before these biomedical waste becomes normal waste or non-infectious waste, or before its journey is over. It has a lot of steps to undergo. The biomedical waste that we generate in the ward, that is step one. It is going to be segregated in our own biomedical waste storage unit. In that process, there is a transport and there is a storage. So there is going to be two more steps there. The segregated waste from our storage facility is going to be picked up by the CBWTF, step 4. What is taken up by the CBWTF vehicle is going to be taken to the facility, step 5. It is going to be unloaded there, step 6. And it is going to undergo the final treatment there, step 7. And the treated waste is going to be finally handled. By that time, it becomes uninfectious and less harmful. So it undergoes minimum 8 steps. So if these 8 steps are not handled or done uniformly across the institutions, from step 4 onwards, things will start going wrong, because every hospital or every institution cannot have the entire story or the entire journey of biomedical waste handled in their own facility. It has to be handled by a common treatment also, common treatment facility. So in the common treatment facility, for it to be uniformly handled, it is important that we segregate, or all the institutions draining into that facility segregate it in the same manner. And to ensure that there is minimum harm done, because each of these 8 steps, there is going to be manual involvement. It's not going to be completely robotic or handless transit. So the entire transit, there is going to be multiple levels of manual involvement, and we have to minimize the chances of risk in these areas. So hence the importance of bringing the whole thing under one umbrella and making sure that all the facilities handle it in the same manner, not similar manner. It has to be the same. Therefore, as Ms. Anu has said in the opening session today morning, it is not guidelines. It has to be biomedical waste rules. It is not optional. It has to be done. And where rules are brought about, it has to be, the implementation would be allotted, or implementation would require the drive of ministry. So naturally, biomedical waste is generated from the health industry. It comes under the Ministry of Health and Family Welfare. Now, in addition to it, what we do not often realize is the Ministry of Environment, Forest and Climate Change, Ministry of Resources and Ministry of Water Resources are also involved in this, because biomedical waste, if not handled properly, yes, it can have direct impact on the healthcare workers or the housekeeping staff who handle the biomedical waste. That is there. But indirectly or in the long term, the consequences are going to be huge on the environment. The climatic changes because of the environmental consequences, the water resources being contaminated, the repercussions are huge. So Ministry of Environment, Forest and Climate Change, Ministry of Resources and Ministry of Water Resources also have their say and their role in the implementation of biomedical waste rules. Now, as I said earlier and during the course of the day, you have heard many times, the biomedical waste rules right now is the biomedical waste rules 2016, but with amendments in 18, 19, and 2020. So as we have heard today, before 1998, we did not have any biomedical waste rules. We did not have guidelines per se. We were all trying to do the best possible. We were all trying to do what we thought was the right way to do. In 1998, we had the first biomedical waste rules, but it did not cover all the aspects, because it can essentially be considered as the first step towards achieving proper biomedical waste management. And if you look at it, 2016 has been the second step, and then few amendments as further steps. So with each step, we are getting closer towards perfectioning the techniques of biomedical waste segregation. The 1998 draft was a good start, but we had a long way to go. And by 2016, it was very clear that it was time to take the next step. So biomedical waste guidelines 2016 was the launch of biomedical waste management rules by Ministry of Environment, Forest and Climate Change. And then this was followed by Biomedical Waste Management Rules 2016 Amendment 2018, in which there was a broad revision of few sections of the Biomedical Waste 2016 and revision of few deadlines. And in 2019, the amendment of 2019 brought on more clarity regarding liquid waste management, biomedical waste management, second amendment, and clarity on the use of chlorinated plastic bags. Not use, rather discouraging the use of chlorinated plastic bags and moving more towards non-chlorinated plastic bags. And that it was, and this around this time that we were hit by the pandemic, COVID pandemic, and with the pandemic came a huge upsurge of the use of PPE, and as a result of it, the biomedical waste that was generated was getting huge, humongous change was there. So the ministry decided that it is always better to, change or segregate COVID waste separately. First, because it's a pandemic and we do not know the repercussions per se. And second, you have to see how much of an increase is there. Is there an increase in the general biomedical waste? Is there an increase only in the COVID biomedical waste? So we started segregating it separately, and that is what the 2020 amendment said. So this is what is currently being followed, the Biomedical Waste Management Rules 2016. But I would like to remind all the participants that the important changes, 3 important changes have been included in the 3 amendments in 2018, 19, and 2020. Now, this is something that we have been hearing again and again. Even in the definition of biomedical waste, it is said that, any waste that is generated as part of treatment, diagnosis, vaccination, immunization, research, so whatever it be, but the waste that is generated at the end of these things will become biomedical waste. But sometimes we forget that the first one, the hospitals, nursing homes, clinics, and dispensaries, yes, it's right there on our face, and we generally do not have any confusion regarding that. But we need to remember that veterinary institutions and animal houses, the waste generated there also belong to the category of biomedical waste. The treatment of animals and humans may vary, but the diseases are more or less essentially same, and the infectious risk that it can pose to the environment and the climate and the water resources are essentially the same. So veterinary institutions and animal houses, the waste generated there is also biomedical waste. Pathological laboratories and blood banks, yes, it is very obvious. Ayush hospitals and clinical establishments, again, they are also dealing with patients, as in patients meaning human beings whose health is not in the optimum condition. These are the people who become patients. So the Ayush hospitals and clinical establishments, the waste generated there also belong to the category of biomedical waste. Research or educational institutions, health camps, medical or surgical camps, vaccination camps, blood donation camps. So whenever a drive is held within our institution, there'll always be biomedical waste bins and everything will be pakka because it is happening inside the hospital. Now, I want you all to think back. When was the last time a camp was done in a remote location by your hospital? There will be a set of inventory. The list will be there ready with our operations or the task units, and they will have the medications, the prescriptions, the hand rub, everything will be ready. How many of us take the color-coded, segregated biomedical waste lined bins with us to the biomedical waste camps? I have heard a few answers saying that we carry it back to our facility and put it into the biomedical. But then what do we say? What do we say in our biomedical waste guidelines? We say segregation at source. So if it is a medical camp or surgical camp or a vaccination camp, for segregation at source to happen, we should be carrying the bins with us. There should not be any manipulation once it is generated. So keep that in mind. I'm sure at least a few of you will benefit from it. And of the people who are listening, at least 50% will implement it. So health camps, medical or surgical camps, vaccination camps, and blood donation camps, first aid rooms of schools. That is something, the first aid rooms of schools, and we are moving fast forward. There is a lot of technology that allows people to check their blood sugar level at home. There are people who check blood sugar level thrice a day, once a day, every day. There are people who take insulin injections at home. Biomedical waste is generated at each of these points. It is time that we started increasing or spreading awareness among people, not just the healthcare providers, but among the general public, wherever there is a chance of generation of biomedical waste. Then, of course, forensic laboratories and research labs. So these guidelines and the code of practice and the biomedical waste rules should be applicable in all these situations. And we, as knowledgeable individuals, should facilitate and propagate the message. So the biomedical waste rules, we already looked at where it applies. Now, there are few situations where it is not just biomedical waste rules. The first one is the radioactive waste. Here it is the Atomic Energy Act. It is the AERB is the one that drives anything that has got anything that is concerned with radioactive waste. So earlier in the day, I had mentioned this once, and I'm for the sake of anyone who may have missed it, I'll repeat it once again. Radioactive waste that is generated as a part of the treatment, diagnosis, or research in radioactive facility, or the waste that is generated, which is radioactive. It is not just biomedical waste. We cannot treat it automatically like biomedical waste. It has a potential. We treat biomedical waste based on its infectious nature and its ability to contaminate. Now, radioactive waste have that potential, and in addition, they have the ability to cause radioactive contamination, or they have the radioactive potential also. So what we do is, or what we promote is, we have to segregate the radioactive waste separately in an area where an ironclad room or a radioactive impermeable room, the waste should be segregated. It should be segregated for a period equal to its decay period. At the end of the decay period, that waste becomes normal biomedical waste. So till its radioactive potential or its ability to cause radioactive exposure is completely or near complete negated, we should not bring it out and treat it like biomedical waste. So at the end of the decay period, what we should remember is its radioactivity has subsided completely. We needn't worry about its radioactive potential, but it is still biomedical waste. The decay ensures protection only from the radioactivity. At the end of it, what is remaining is still biomedical waste, and we have to dispose it like any other biomedical waste. So what you can do is the radioactive waste, segregate it as blue, red, white, and yellow, store it in the decay area, and then at the end of the decay period, remove it as biomedical waste. We again want to minimize manipulation. That is why I recommend that we segregate it color code wise, store it, and then discard it. So you may ask me what the decay period is. It depends on what exactly is the radioactive chemical that you're using, whether you're using iodine for therapy or whether you're using radioactive chemicals for diagnostic purposes. So each radioactive chemical for the procurement itself, for the procurement of each radioactive chemical, you require ARB licensing. So whatever it is that you are licensed for, you should be capable of handling the biomedical waste and storing it for the appropriate period of time. And this is something that is beyond the purview of any infection prevention control individual. We cannot memorize or have all the decay periods at the tip of our fingers. But if there is a radioactive facility in your or a radioactive unit in your facility, there will definitely be a AERB certified radiation safety officer. Now, this radiation safety officer may not know the infection prevention control aspect of it, but our infection prevention control person does not know the radioactive aspect of it. So what do? It has to be a combined task. It has to be a collaborated effort. Then alone, we can minimize or ensure that there is no harm coming out of it. Then we have the hazardous chemicals rules of 1989, solid waste covered under MSW rules 2000, lead acid batteries under batteries rule 2001, hazardous waste management handling and transboundary movement rules 2008, e-waste rules 2011, hazardous microorganisms rules 1989. So among this, one of the things that I would like to say is the solid waste rules that also gives color-coded segregation. It says dry waste in blue and wet waste in green. Something that I would request all healthcare facilities to ensure is in our biomedical waste rules, we have already allocated blue for something. If possible, do not bring in the dry waste blue into the biomedical waste facility, or if you have to, give it a separate color code or separate type of bin, separate shade of blue, something like that. Because the solid waste rules are applicable to all institutions. It's not made just for healthcare institutions. So they have chosen the 4 neutral colors. But where healthcare facilities are concerned, blue means something to us already. So for dry waste or for solid waste, dry waste, ensure that it's a different shade of blue or at least a different type of container, so that there will be no mixing of our biomedical waste with the dry waste. Because if at all a biomedical waste comes in contact, if one syringe or one needle comes in contact with 80 kg of paper waste, the entire 80 kg automatically becomes biomedical waste. So anything that a biomedical waste comes in contact with automatically becomes biomedical waste. So keep that in mind. We do not want our biomedical waste blue items even by any remote chance to get into the dry waste, which is municipal waste. Okay. And another one that will come under this is the battery waste. So I'll come to that again. The statutory requirements. So like what was said by our faculty earlier, for an institution to start working as a healthcare facility, they should get a NOC from the State Pollution Control Board. The NOC is for the no objection certificate is for collection, compilation, and storage of biomedical waste. For storage, generation and storage of biomedical waste itself, we require NOC from State Pollution Control Board. And only after procuring this, we'll be able to register with any common biomedical waste treatment facility. There are certain terms which are defined in the biomedical waste guidelines. That is the occupier, the operator, the prescribed authority, and the control committee. So these are fairly straightforward, and I think you can understand it by going through it. Now, what does the biomedical waste 2016 rule defines? The hospitals can segregate biomedical waste, and who has to give to a biomedical waste treatment facility, CBWTF, and who can start a biomedical waste treatment plant. If suppose a hospital feels, I have 24, 25 acres within my campus itself, can't I start my own waste treatment plant? If every facility starts like that, it will be difficult to monitor and supervise and ensure that it is correctly being done. And they should have the right motivation and the right resources also. So currently what our rule says, if a facility has, if a institution has within 75 kilometers of it, a common biomedical waste treatment facility, if it is yes, then we have to send the biomedical waste to that facility. If it is no, there is no biomedical waste treatment facility within 75 kilometers of that institution, then you may procure, you may apply for permission to start a biomedical waste treatment plant. Who do we apply to? We apply to the State Pollution Control Board. And then if they give us the sanctioning and we start the biomedical waste treatment plant for that institution, it will be periodically inspected by the State Pollution Control Board whether all the norms are being met. So it is, the radius is 75 kilometers. This is what the rule says. But in rural India, I think what we are facing is the other aspect. There are no facilities within 75 or 100 kilometers, and it may have to travel a long while. But yes, like I said, from 1998, we have made a lot of improvement coming to the 2016 rules, and I have great faith and I believe that the next rules will be addressing all the challenges that we are facing today. Then salient features of what the amended BMW rules are. Like I said, the 2018, 19, 20 amendments are there. And what has changed between 1998 and 2016. So pre-treat the laboratory microbiological blood samples and blood bags through disinfection or sterilization at site. So even if the waste is going to the biomedical waste treatment facility, at site, at the institution that is generating the waste, before you give to the CBWTF, it should be pre-treated. How can you pre-treat it? You can either use autoclave, you can use microwave, or you can use chemical treatment. All these three options are given in the biomedical waste rules. You can choose any one of these three options for pre-treatment of these waste, but pre-treatment should be done before you hand it over. So that is one of the aspects which is present in the amendment, 2019 amendment. Phase out of the use of chlorinated plastic bags, gloves, and blood bags within 2 years. That is stated clearly in the 2019 amendment of 2016 rules, because chlorinated plastic bags are not environment friendly. And if at all it is exposed to high temperatures of an autoclave, it can have exothermic reaction. It will generate a lot of energy by itself, and it causes occupational hazard for the people who are handling it. So chlorinated items are going to be phased out eventually. That was one of the aims of 2019 amendment, but we have not moved. Frankly, we have not reached much impact, or we have not gained much momentum on that, because as we all know, 2019 we got derailed because of the pandemic. But I hope and I trust it is being implemented. Providing training to all its healthcare workers and immunizing all healthcare workers regularly. So the training aspect of healthcare workers was not initially covered in the 1998 rules, and it was only briefly touched upon in 2016 rules. But by 2018, they have come to the conclusion that providing training to all healthcare workers is the key. Having rules is not just enough. And like I said, the waste generation and waste segregation is to be done at source. So whoever is there at the source, whoever is generating the biomedical waste, they have to be treated, they have to be trained. Establishing a barcode system for bags or containers containing biomedical waste for disposal. If done well, it'll take us a long way. And we are in the process of getting it well, just that we have to get all the stakeholders together. And till that happens, I request all the people who are currently doing it to not lose faith in the system. It is happening. It is slowly happening, and it is getting implemented. And biomedical waste has been classified into 4 categories instead of 10 to improve segregation of wasted source. In the beginning, when the biomedical waste rules 1998 came, there were 10 categories. 10 categories, and it was not very student friendly also. If you try to teach students the 10 categories, it won't percolate. Now it has been converted into 4 categories, and in yellow we have divided into subcategories A to H. So that is a better approach, and it is associated with better outcomes, I like to believe. So the color coding has already been covered in detail by Aruna ma'am. And the salient features of amendment, the other factors, one is the 75 kilometer radius has already been covered. Then the operator of a common biomedical waste treatment and facility to ensure the timely collection within 48 hours from the healthcare facilities and assist the healthcare facilities in conducting the training. And the third one of the important aspects is the annual report, which has to be submitted, and the format is also given along with the biomedical waste guidelines. The annual report has to be submitted in the prescribed format on or before June 30th of every year. Then major accidents, reporting of major accidents. See, from the perspective of an infection control professional, for me, every needle stick injury is an incident. Every mercury spill, if there is still mercury, that is also an incident. But that is not what they mean by accident reporting. So if you look at the last line, exclude accidents like needle prick injuries and mercury spills. Why are they telling us to exclude accidents like that? Because these are the accidents or the incidents for which we ourselves can find the root cause analysis. We can do the root cause analysis and we can implement the corrective and preventive action. So whatever we can sort by ourselves, we can. Now, the same thing, the incident report, what we do inside the facility, inside our institution, that being escalated is what the accident report is. If there has occurred an adverse event in which we as a healthcare facility, we ourselves cannot do the root cause analysis, or even if we do the root cause analysis, we can't do the corrective and preventive action. Those are the things that they want us to report as accidents. For that also, they have given a designated format. What has happened, when, who has reported, when was it noted, who all were involved, how many people were injured. And it is an elaborate format. We just have to fill it and give it so that they can do the root cause analysis and initiate a corrective and preventive action pan state. Okay. So while handling of biomedical waste having potential to affect large masses of public, including the toppling of the truck that is carrying biomedical waste. If the CBWTF truck has come and they have taken all our waste, but it has toppled. Now, that is an event. Can we do the CAPA by ourselves? No, we have to report it. It has to come from higher up above, and similar incidents should be prevented or measures should be taken to prevent it in a larger context. So the release of biomedical waste into water body by accidental, but still needs to be reported. Fire hazards, blast during handling of biomedical waste. So these kind of accidents should be reported in the accident form. And in our annual report form, one of the things is how many accidents have you reported? How many of them have been closed? So it has to be a symmetrical and fully covered report. So the major differences between the 1998 rules and 2016 rules, anyone who has been in healthcare industry for 2 decades would already automatically know. Earlier in the 1998 rules, it was applicable only to occupiers with more than 1,000 beds, and the rules were restricted to healthcare establishments with more than 1,000 beds. But now every occupier generating biomedical waste, including health camp and Ayush facilities, require to obtain authorization. In 1998, the rules, the operator duties were absent. Here, the operator duties are very well defined. 1998, biomedical waste categories were divided into 10. It was exhaustive. Now it is divided into 4 categories, but trust me, nothing has been excluded. All the biomedical waste, which was classified earlier, is still biomedical waste, just that it has become a little more teaching friendly or educator friendly. So the format of annual report has also been included in the 2016 guidelines. And the QR code system, in case there are facilities which are not yet using the QR code system, this is something, a slide that I hope will help to convince you to use the QR code system, already covered by our earlier faculty also. The tracking of biomedical waste, daily check on occupier and CBWTF, preventing pilferage of biomedical waste at occupier and CBWTF, identification of source and generation of biomedical waste in case of improper disposal. That is textbook data. Now, if you want me to simplify it, I would say, suppose 70 bags or 70 kg of yellow waste was generated in hospital ABC, and it was taken up by the biomedical waste treatment facility. They have come and picked it up. So at the time of picking up, they'll be scanning the barcode. So it is already registered. Hospital ABC has generated 70 kg of yellow waste on 23/9/2023. So they have scanned it. At the time of reaching the common CBWTF, again, the people there will be scanning the barcode. So at the time when they scan the barcode, suppose if under hospital ABC, only 65 kg is being scanned, then we know that 5 kg waste has gotten somewhere. It has either pilferage or accidental drop or something has happened. We should be able to track it. It should not happen. What has been handed over by the healthcare facility and what is reaching the CBWTF should tally. So that is one of the things that can be ensured by the QR code system. Another thing is there might be erroneous practices. No one will do it purposefully, but someone might accidentally do it. Suppose there is a inflammable or something that inflammable material accidentally entering into the yellow bag, and in the incinerator it undergoes explosive reaction, or at the nick of the time, it was a near miss, in the last minute someone saw it and prevented it from going into the incinerator. Now we want to know in which hospital that erroneous practice is there, because no one is going to do it on purpose. Either they lack the information, either education was lacking, or there is no proper supervision, or they require training. Whatever it is, unless it can be traced back to the right institution, we will never be able to do a proper RCA and CAPA. So identification of the source of generation, the last point, identification of the source of generation of biomedical waste in case of improper disposal. Hence the importance of QR code system. So the biomedical waste rules amendment, like I said, 2018, 19 and 20. In 2018, municipal waste handling should be substituted with solid waste management guidelines 2016. Hazardous waste management handling and transboundary movement rules 2008 should be substituted with hazardous and other waste rules 2016. E-waste management rules 2011 substitute with e-waste management rules 2016. And all the healthcare facilities shall make available the annual report in its website. So that came in the 2018 amendment. So this is the 2018 amendment. Then another aspect that has been introduced in the 2018 amendment is in the 16 rules, they say that the diagram that the picture that is shown on the left side, according to the 2016 rules, you can use leak-proof boxes or containers with blue colored marking. That was acceptable for metallic implants according to the biomedical waste guidelines 2016. But in the amendment 2018, they have said that you should use proper bins. You should use proper bins. It should be puncture proof and leak proof. It should not be cardboard boxes. They have very clearly said that. So right now, what the guidelines say, the 2018 guidelines say, is what the picture that is given on the right side. It should be proper bins, not cardboard boxes. This is something that I have found to be, this is an information that I found that has not reached or percolated to the ground level. So I request you all to please make note of this aspect. No more cardboard boxes with blue marking. It should be a blue container. So what has changed in 2019? 2019, they have come out ahead a little stronger, a little emboldened by the success of 2016 rules. They have come and said that you shall make a day-to-day update. It shall be compiled into a monthly report, and the monthly report shall be compiled into an annual report. The monthly record shall be displayed in the hospital's website. So whatever the amount of yellow waste, blue waste, white and red waste that you have generated, the hospital has generated in that month should be reported or should be made visible in the hospital's or the institution's website. So the annual report also has to be made available. Then healthcare facilities having less than 10 beds also to have the output discharge standard for liquid waste by 2019 end. Safe disposal of COVID waste, the need for this, why exactly it was brought about, I have already discussed. Then the penalty for non-complying healthcare facilities as per the Environment Protection Act 1986. This is what the penalty is. Punishable with imprisonment for a term which may extend to 5 years, or with the fine which may extend to 1 lakh rupees, or with both, And in case the failure or contravention continues, an additional fine for every day, 5,000 rupees for every day of such failure. So that is the penalty for non-compliance. A term which can extend up to 5 years and a fine which may extend up to 1 lakh or both. So the reference for this entire discussion is the guidelines, or the entire day's discussion, if you may, is the guidelines for management of healthcare waste as per biomedical waste management rules 2016. And that another aspect that has come up again and again during the discussion is regarding the battery waste or the e-waste. So the e-waste rules have been updated in 2022, and e-waste is something that is difficult for a hospital to deal with by itself. E-waste will include anything that is electric, not electronic, electric, batteries, anything that has rechargeable or disposable battery. All of this would come under e-waste. So if you take any home, any institution, even healthcare institution, we all have devices which are battery operated, right from our glucometer onwards. There are a lot of devices which are battery operated. So it is not possible to bring these under the purview of biomedical waste. And the different ways in which we handle biomedical waste. What are the treatment options that we have? We have autoclaving, we have incineration, we have chemical treatment. Now, battery waste are something that you cannot expose to any of these. It will result in a hazard of huge proportions. So what 2022 e-waste guidelines says is there are two options. One, you can give to a certified procurement agency, which is certified to receive e-waste, or you can give it, return it to the manufacturer itself, manufacturer themselves. Manufacturers are expected to take returns if it comes in bulk. So these are the two options that are put forth by the e-waste guidelines 2022. But yes, as you and I both know, it has not reached complete implementation, but I'm pretty sure we'll get there because battery waste is increasing, or the amount of battery waste generated per day is increasing by a lot. And that is a kind of waste. If it gets into the wrong place or if it gets into a fire, it can cause a lot of safety issues. So that will eventually get implemented. So if you have any questions, I think we'll have the